Hi everyone, welcome to HerniaTalk Live. Just want to thank you all for joining me. My name is Dr. Shirin Towfigh. Thank you for joining me every Tuesday live on Facebook or on Zoom. And also for those of you that then watch this pre-recorded on YouTube usually. I just wanted to thank you all because you're following me and you're making me and inspiring me to do more of these talks. Thank you for following me on Twitter and Instagram at HerniaTalk, on Facebook. And today we will be talking about abdominal pains as a medical mystery. If many of you are following me on social media, you'll see that I've been discussing a couple of patients I've had recently where they've had these medical mysteries of abdominal pain. I think the last one was 17 years of pain, not really knowing what it was, and they've been through so much. And so I get many patients like you that reach out to me mostly because I really enjoy solving problems. And I was explaining this to a friend of mine yesterday. A lot of people see problems and they run away from it. I see a medical problem and I run towards it because even as a child, I enjoyed solving puzzles. I would have these little puzzle books, kind of mind twisters. I enjoy solving crossword puzzles, Sudoku, whatever it is. So I do enjoy figuring out medical mysteries. Now, it's been a while since I've been in medical school. I graduated medical school in 1996. And ever since then, I've been a surgeon. So most of what I know, of course, is surgical. And I have a very narrow specialty, which is hernia surgery. And in that narrow specialty, I really know my stuff on hernias, especially in the groin. But anything hernia related, I know it. And I know all the rare stuff, really rare perineal hernias, Petit's hernias, lumbar hernias, Grenfell hernia, all these fancy names for fun hernias that can occur. And I've treated them. I've treated these rare sciatic notch hernias. And what's another really rare one? I just recently did a Grenfell hernia. So what I'm trying to say is I have experience in hernias, really, like that's my thing. And so a lot of people come to me because they think they have a hernia or they haven't really figured out what the problem is, and they've seen me write about things or watch me on HerniaTalk, and they're like, okay, maybe she can figure this out. Maybe what I have is a hernia. You don't necessarily have a hernia when you come to me. Oftentimes I figure out another reason for your problem and pain, but what I think people have figured out is I do enjoy the challenge. And if it's a hernia, great, I can fix it. I know all about it. And if it's not a hernia and it's outside of my scope, it could be a medical problem. It could be lupus that's causing your symptoms. I kind of will be able to then help you navigate the medical system to get you care. So lately, I've had a handful of really unique medical mysteries that I've been able to solve, and the patients are like, I mean, one patient is down to 90 pounds because of her mystery abdominal pain and chest, and actually hers is more chest pain, but it's not really abdominal pain. But understanding how the body works and really remembering what they taught you back in medical school, or maybe there was this one scenario where you read it somewhere that you remembered. Or I love doing research. Like I do my own research, I presented a lot of talks, and then I love Googling things and reading more and reading literature and stuff. So I thought it'd be kind of cool to spend today's hour talking about abdominal pain and how it can be hernia related versus non hernia related, and how to kind of solve medical mysteries, because this past several weeks have been a slew of really unique diagnoses that I've gone through. And of course, if you have any questions that you'd like to submit to me, I will answer them as we go through. But I had some pre-prepared for you, and so I thought we'd kind of go through this already. So why is abdominal pain such a medical mystery? And I'd like to tell you it's because there's so much going on in the abdomen, number one. There's the abdominal wall, which is kind of my territory. There's the internal organs within the abdominal wall, which is as a general surgeon, what we deal with, but gastroenterologists deal with it, urologists deal with it, gynecologists. Your spine can cause abdominal pain if it's like a nerve-related problem. And then also something that's very interesting that was taught to me is that the chest is the mirror of the abdomen, and the abdomen is the mirror of the chest. So oftentimes, not oftentimes, but it can happen where you actually have a chest problem, but it presents with abdominal pain. Very simple, pneumonia. Pneumonia can cause abdominal pain. So if you have a left-sided pneumonia, you can have left-sided abdominal pain. If you have a right-sided pneumonia, you can have right-sided abdominal pain. The reverse is also true. You can have, let's say, pancreatitis, which is inflammation of your pancreas, and that can cause chest pain in the upper abdomen. And I have one lady recently who has severe chest pain. Her story is very interesting. Over the past year and a half or so, she just feels this tightness around her chest. Sometimes it's difficult to breathe. It gives her nausea. She can't wear a bra. She can't really wear any constricting outfits around her chest. And so a lot of the attention has been around her chest. And I'm willing to bet, because I think I solved her medical mystery, which I think is abdominal in nature. But like I said, the chest is the mirror of the abdomen. So a lot of the symptoms she's getting, even though it's chest related, she feels like she gets short of breath. She's otherwise normal and healthy. She gets these weird blood pressure fluctuations. It can be from an abdominal problem. So really interesting stuff. The other reason why abdominal pain is so difficult as a medical mystery, I think, is as clinicians, as doctors, we've absolutely lost the talent of diagnosing things based on just sitting and talking to the patient, number one, and number two, looking at diagnostically at labs and physical exam. So when I was in college, I had a mentor. His name was Dr. Saleh. I may have mentioned him on this show before. He was a nephrologist. The majority of his patients did not have kidney issues, which is what a nephrologist takes care of. He was a super smart doctor. He could just listen to you and examine you, and he knew, and maybe look at some labs, and he knew what was wrong with you. Whereas today, everyone has to get imaging, and they're not even good at reading the imaging. So it's like this horrible oxymoron where the doctors don't even touch you anymore. You can't imagine how many patients I've seen where the patient's like, I never got a physical exam. And we've kind of lost the talent and the technique of doing physical examination, and we're highly reliant on technology, at least in the United States. Now, this doctor, mentor of mine, trained in Canada at McGill, which is a fantastic institution. And at that time, at least in the United States compared with Canada, McGill and Canada were much more likely to train really astute clinicians, as opposed to the US, where we have MRI and CAT scan and PET scan and another MRI, and are so reliant on technology. You can't imagine how many patients I've seen that have a hernia in the groin or in the belly. I mean, it's groin pain. Why are you getting colonoscopy? Colonoscopy, endoscopy, all these GI studies makes no sense to me, because the symptoms associated with the GI are very different often than the symptoms that you have with like an abdominal wall problem. So it doesn't make sense to me sometimes why certain decisions are made, and that's kind of where I'm at. So I actually enjoy that. My mentor was my kind of role model for that kind of stuff. And I really strongly believe in the history. I think the story, everyone has a story. I need to hear your story. What is the story? And what are the little details within the story? What are little tidbits? Some patients come to me and they're like, I don't want to overwhelm you with all my story, or like, they don't tell me certain details because they think it's going to scare me away and I'm going to be overwhelmed with so much information. And yet that little bit, the fact that going up hills hurts more, the fact that liquids hurt, but solids don't when you have a meal, or solid meals hurt, but liquids don't. Those are little tidbits of information that are really helpful. I had a patient that, this is a good one. He was a kid, I think he was 16 or 17, and just the worst abdominal pain. He would get descended to, and no one could figure out why he had this abdominal pain. They sent him to me, a little bit chunky kid, overweight, and like maybe he has a hernia. He didn't have a hernia. But the tidbit was this: if he had one of these abdominal pain attacks, he would go sit in a hot tub, like a bathtub. The mom would say, I would know that he's feeling bad again when I would hear the bathtub water running. And he would sit in a warm bathtub and his pain would be so much better. Does anyone know the diagnosis? That little tidbit alone is the diagnosis. Like, all you have to hear is that I have your diagnosis. So it's abdominal pain that is better with sitting in a hot bathtub. We'll sit on that one for a while. We'll let you mulch on it. But it's little tidbits like that that really excite me, because those are the ones that you're like, oh, this is so cool. I solved it. I cracked the case, so to speak. All right. So moving along, how can you differentiate among different diagnoses for abdominal pain? Well, this is a very good question, because if you have a good clinician, physician, could be a surgeon, doesn't need to be a surgeon, but someone who could really ask the key questions to then be able to differentiate, is this abdominal pain from the GI tract? Is this from the abdominal wall? And then at least that way, kind of take the diagnoses down a certain pathway, instead of being like, oh, let's just kind of rule everything out. So for example, abdominal pain that is the GI tract is often changes. First of all, it's usually patients will say my pain is exactly here and it never moves, because intestines move and colon moves and so on. So it tends to migrate if it's the intestinal tract. And then where it starts and where it moves is indicative. It'll shoot towards the back, for example, or up towards the chest, or down towards the pelvis. It's often around the belly button, because the nerves all kind of coalesce in that way. And then, whereas abdominal wall pain is almost always activity related. So you're better when you're flat, you're not doing anything. You're worse when you're up and about and bending and running or walking, whatever. So activity related pain is almost never GI tract, with very few exceptions. And pain that migrates around is almost never hernia, with probably no exceptions. If you got pain sometimes here, sometimes there, a nausea, bloating, that's usually GI tract. Let's see, we just got a question come on in. Significant pain I have significant pain at the xiphoid process, which is that bone right at the bottom of your chest here, right down here, and along the left lower rib cage and diaphragm after laparotomy down the midline. Also, I have non-functioning abdominal muscles. Any ideas what can be done? Okay, that's a good question. So pain of the xiphoid process, which is this bone, can be because you actually have a fracture of the xiphoid. So that can happen if you broke it, like you got hit somewhere, if, let's say, a baseball hit you, or if the surgeon went all the way up and fractured that, sometimes by retraction, like they like try to go in there and see what's up, and that bone piece got fractured. And so CAT scan can show you, or a CAT scan or a good x-ray can show you if that cartilage there is broken. Sometimes, depending on the laparotomy, if the laparotomy goes all the way up, laparotomy is basically a scar, usually up and down on the abdomen. So if the laparoscopic goes all the way up towards the xiphoid, usually for, let's say, abdominal, upper abdomen surgery, like stomach, pancreas, liver, then sometimes they have to go really high up and the xiphoid's in the way. So they either split the xiphoid or they go to the side of the xiphoid. And then at the end, they have to close it. And sometimes using the closure, either you get a hernia there, and the hernia there, it can be painful because it's separated in that area and things try and poke in that area. Or the way it's closed kind of traps that xiphoid process in the repair. So it seems that the pains at the xiphoid process and along the left rib cage or diaphragm after an up and down laparotomy incision. And you also have non-functioning abdominal muscles. So I don't know what you mean by non-functioning abdominal muscles. If you have an incision this way and an incision this way, so an up and down incision and one that crosses it either at an angle or perpendicularly, that can cause nerve damage to the muscles because the nerves come in down diagonally. And so if you cut the nerves this way up and down, usually that's not an issue, but if you cut it up and down and you cross cut it, then this lower corner of those two can have both sets of nerves cut, and that can cause non-functioning abdominal muscles. So if you've had more than just an up and down laparotomy, part of it may be from a hernia. And then, you could have adhesions from prior surgery. Is your stomach stuck to that area of the xiphoid process? Often not. The liver is usually in the area. And then lastly, it could be something deeper to the xiphoid process. Most patients with peptic ulcer disease or gastric ulcers or acid reflux have burning and pain exactly at that xiphoid process. It's described as like a knife stabbing in the area. So it could be none of the above, completely unrelated to your laparotomy, and really just an internal area where your esophagus or your stomach is burnt by ulcers and has inflammation like esophagitis or gastritis. In which case, endoscopy is the next step. And in doing the endoscopy, they'll actually examine the inner linings to see if it's involved in inflammation or ulceration. And some people have hernias there. You can have what's called a hiatal hernia, where your stomach or some other organ travels up the chest, which it shouldn't, and that can cause pain. So see, just one area of the body, right? Xiphoid process alone can have medical problems, surgical problem, hernia, GI tract, etc. It's usually not a bony problem. It's usually not a nerve problem. So some of those other kind of diagnoses you can take off your list. So I hope that was helpful. So going back to differentiating the diagnosis for abdominal pain, we talked about activity. So activity-induced pain is almost always musculoskeletal because of the muscle, and hernias are considered part of the musculoskeletal system, whereas GI tract is almost never activity-induced. So if you're being told, okay, let's get a colonoscopy or endoscopy, usually that's not necessary as part of the workup. It's just a comfort zone for the doctors because they're uncomfortable with other diagnoses. So when do hernias cause abdominal pain? Good question. First of all, not all hernias cause abdominal pain or any pain. So just because you have a hernia doesn't mean that that's the cause of your pain, especially since hernias are so common. So it's very good to have an open mind and not just repair any hernia and blame that as the cause of your pain. I see every year I see maybe 4 or 5 patients that had a hernia repair that absolutely did not need to be performed for treatment of some type of abdominal pain. And the abdominal pain was separate. It was Crohn's disease. It was prostatitis. They had some ovarian endometriosis, let's say. So they had the hernia repair, which they never needed. And their underlying problem never got solved. But now they have a complication from their hernia repair. So it can happen. Every so often I see a patient, very complicated, can't really figure out the pain. I'm like, maybe it's from the hernia. Let's fix the hernia and reevaluate. That's okay. But if it's glaringly not from the hernia and someone diagnoses hernia as part of the workup, then you have a hernia repair that you never really need. And now you have a complication from that. Plus, your underlying problem is not better. That's not the best outcome that you would want. So that's what we're hoping that you don't get. Which is why I say every several months I bring this up. Always get a second, maybe even a third opinion when you are told you need to have surgery. I don't care if I'm the surgeon recommending it or someone else is recommending it. I highly recommend that you see more than one doctor because you're going to go into that surgery, therefore, with a better understanding of what your problem is, getting more of your questions answered. And if there's a conflict between the two surgeons, you can help figure out like what that is so that you don't necessarily undergo an unnecessary operation. All right, here's another question. I believe from the original question about the xiphoid. You mentioned hiatal hernia traveling up the chest. What type of pain comes with this? I went to a doctor thinking this is what I had and was asked to get a CT scan, which shows two ventral hernias with bowel in them. I think it is more than that as my pain is in the middle of the chest with spasms. So chest pain is almost never from ventral hernias. Ventral hernias are hernias in the abdominal wall, usually in the front of the abdomen. It almost never causes chest pain. The pain that can be caused by chest pain, things that can cause chest pain, of course, are the heart, but it's acid reflux and esophageal spasm, esophagitis, and anything else that competes with the esophagus for space. So a hiatal hernia is a hernia around the esophagus and stomach, and either the stomach goes up into the chest or sometimes other organs go up in the chest and compete for space, and that can cause chest pain or what we call retrosternal pain. So here's your sternum, pain behind that, or sometimes we call it like acid reflux can cause the same problem, but are spasms in that area. So the types of pain from hiatal hernia can include nothing or regurgitation of food, acid reflux, food reflux, worse when you're lying flat. It can be a sharp stabbing pain into the chest. Some people get shortness of breath or anxiety. Some people get heart palpitations even, but spasms of the chest can occur, or you can have an actual esophageal dysmotility where the esophagus doesn't empty very in a very coordinated way. And because it's doing that, it causes spasms and pain. So a good foregut surgeon can help you with that. Now, here's another question. I have acid reflux, gastroesophageal reflux disease, also known as GERD. Do you think a chiropractor should ever adjust this? Okay, so I have read about this because I thought it was interesting that a chiropractic would adjust for acid reflux. So the short answer is no. I do not believe a chiropractor should adjust for it. Acid reflux is either a functional or a mechanical problem. If it's functional because you just have abnormally loose esophagus sphincter, and so every time you eat, the food goes beyond the esophagus, it refluxes back up. There's no amount of spinal manipulation that can treat that. There are patients that have acid reflux because they have a hiatal hernia. Their stomach is higher up in the chest than it should be. It should not be in the chest at all. And so there are physical therapists, naturopaths, and chiropractics that then massage the stomach down into the abdomen away from the chest and help relieve patients' symptoms. It lasts hours to days. It's not a treatment at all. And it is, how should I explain this? It's like massaging, and I don't even know what kind of explanation I can give. You're basically massaging the stomach down out of this hole, but it doesn't treat the hole and it doesn't treat the symptoms more than the amount of time the stomach is down in the abdomen, which may be hours to days. So no, I do not believe a chiropractic should ever adjust for this. Sorry. Next question. I have a physical therapy patient, post-op hernia repair, inguinal hernia repair with mesh. Now the patient has terrible aching in the left lower quadrant, worse than the hernia pain for the past 5 months. Have you seen this before? Yes, of course. So if it's a left lower quadrant or left inguinal abdominal, left inguinal hernia repair, and now they have left lower quadrant abdominal pain, it can be directly as a result of the hernia. If it's on an opposite side of where the hernia was repaired, it's probably not related to it. But depending on how the inguinal hernia was performed, laparoscopic or open, with mesh or without mesh, you can get entrapment of bowel into the area, scarring and adhesion of bowel to the area, a hernia within a hernia, balling up of the mesh, tearing of the area, all of those, or nerve damage, and any of those can cause abdominal pain on the same side as the hernia repair. If the pain's on the other side, then it's unrelated to the hernia repair. Next question. Hello, doctor. Can you please touch on nursing women having hernia surgery? Could they delay it until they finish breastfeeding? In fact, they should. We've discussed this on a couple of our different GYN episodes. So women that are nursing, i.e. they are breastfeeding, have the same kind of risk of hernias than any other person who's out there. In fact, the act of giving birth where you're straining may exacerbate an underlying hernia. So we do not recommend that any hernia be repaired electively during pregnancy, shortly after pregnancy, or anytime while breastfeeding. The reason for that is the hormonal changes that are in place are there to allow for your tissues to be very loose and accommodate for the increased abdominal distension for the pregnancy. And those hormones linger on while you're still breastfeeding. So your abdominal wall really doesn't have the same capacity and resistance than it did before pregnancy. And so suturing on those tissues and closing those tissues will be an inadequate repair during the time of the hormonal levels. So the recommendations that we make is that elective surgery be delayed for 3 months after the last day of breastfeeding. So go ahead and finish, deliver your baby. If you choose to breastfeed, continue doing that. Once you're done with that, at least 3 months later, you can then see a surgeon and consider hernia repair. Next question. I have had lower left abdominal pain and soreness for 6 months. Incredible amounts of gas and pain now radiates around my back and under the shoulder blade. Left lower abdominal pain. Okay. Colonoscopy, MRI, the pancreas are all negative. It hurts to bend over. It often feels like a contraction or squeezing next to the left of my belly button. CAT scan of the abdomen also negative. The back pain is better when I'm lying down. I also have pain now occurring in the inner thighs that come and go. Any ideas for me to look into with abdominal surgeon? I'm scheduled to see, any ideas for me to look into with the abdominal surgeon I'm scheduled to see next? I've had 3 laparoscopic operations for endometriosis and hysterectomy. I've also had pudendal neuralgia, but I've been asymptomatic for 5 years. Oh my, you've had a lot going on. Okay, so if you have multiple laparoscopies, you're definitely at risk for having a belly button hernia. It's an incisional hernia at the belly button. And that can cause back pain. It can cause pain to the left or right of the belly button. And it usually doesn't cause chest pain. So at the very least, make sure you don't have an incisional hernia at your belly button, which the CAT scan or MRI may show and may have been missed by the radiologist that was actually there. So I would have a second eye look at the MRI and CT scan to double check you don't have a belly button hernia. Because if you had one if you had multiple laparoscopies, you're definitely high at risk for having an incisional hernia at the belly button. With endometriosis and hysterectomy. Okay, so you've had the hysterectomy, which means it's unlikely that you have any endometriosis related problems. Incredible amounts of gas can also be related to hernias. Hernias can cause bloating. and then repairing of the hernias can repair all that. Then you also have groin pain going down or pain that goes into your inner thighs. Inguinal hernias can cause inner thigh pain. There's very few things that can cause inner thigh pain. Inguinal hernia is one of them. Spine disorder or sacroiliitis is another one, and a hip disorder. All three of those can cause inner thigh pain. If it's on both sides, it's probably not your hip, because most people don't have equal amounts of hip injury on both sides. If it's hernias, you can have hernias on both sides. That's possible. Both of them causing inner thigh pain. And then if it is sacroiliitis, that can also occur on both sides, though often all of these can occur usually on one side. So any autoimmune disorder can cause there is an autoimmune disorder that causes sacroiliitis too. So it's the SI joint in your back can be inflamed, and then that can cause pain that radiates to the groin and then the inner thigh. So those are all things to look into. They should re-review, if you're seeing the abdominal surgeon, they should re-review your imaging for a belly button hernia. They should also examine you and review you for an inguinal hernia. They should examine your lower back for sacroiliitis and do a hip exam to make sure you don't have any hip problems. And let's see, you bend over, you feel contracting, squeezing left side of your belly button. That sounds like a belly button hernia. Pain radiating around the back and under the shoulder blade, that can be belly button. Yeah, for sure. I would love to hear if you can come back to us after your examination with your doctor. I'm so curious. I don't even know you, and I want to know try and solve this for you. So of course, I'm free to look at I'm available to look at your images and review a story if you want to do what we call an online consult. But I would love it if you could come back on HerniaTalk and give us more information about what they thought was going on after you see your abdominal surgeon. I do have a small umbilical hernia, but they said it shouldn't cause pain. Wrong. Umbilical hernias absolutely can cause pain. It can cause bloating, distension, back pain, pain to the left or right of that belly button. And some people have pain that shoots down towards the pubis, but not to the inner thigh. Yeah, they're wrong. They're wrong. Okay. See, I've never even seen you, and I already kind of figured it out a little bit. All right. What is your take on red light therapy used for scar tissue of the abdomen? Yeah, red light therapy is great. Ultrasonic therapy, red light therapy. The way it works is it reduces inflammation and increases blood flow to the area, and it's considered a treatment to reduce scarring and scar formation. So as part of surgery or anything, you have this inflammatory response, which then induces scarring. So if you can reduce that, it can reduce the scarring. So I'm a big fan of red light therapy. It's hard to get. Not everyone offers it. Let's see. With regard to your observation that abdominal wall pain is precipitated by activity, Dr. Zolan, in his book, Deciphering Groin and Pelvic Pain, observes on page 36 that the pain of the pubic plate disruption occurs not during the exertion, but after, often the morning after. Can you kindly comment on this and how to explain this phenomenon? Yeah, so we did not discuss, I talked about hernias. We did not discuss muscle strains and kind of orthopedic injuries. So many patients with orthopedic injuries also have activity-related pain. In some patients, that activity is immediate. So the minute you have the activity, you have pain. In others, it's delayed. So you kind of, it's almost like, how should I explain it? It's like a soreness that you get after overuse of an injury, in that you kind of work, and the actual tension or use of that muscle that is strained is not the problem. It's as it's in recovery that it gets more, that there's more inflammation in the area. And when you gain inflammation, that causes the pain in the area. So in other words, this sports plate disruption issue is really a muscle strain. The muscle, let's say, is attached to the bone. It's really not doing much. And when you're doing certain activities, it can pull away from the bony attachment. Once it does that, it could be painful to do certain activities, or it can get inflamed with certain activities. And when that inflammation peaks the next day, similar to why people are in more pain after the one day or 2 days after a marathon, and they don't really feel it during the activity. It's when the inflammation settles in, you get increased pressure in the area. Hope that was helpful. Okay, next question. I have extreme abdominal pain and pelvic pain that started getting very bad several months ago. I had a ventral hernia repair done 7 years ago, which was done using sutures because I'm an athlete and have very healthy muscles. I'm curious how big your ventral hernia was. I had an umbilical hernia repair and scar revision done 2 years after that. So where was your ventral hernia? If you can let me know about that. If it wasn't an umbilical hernia. Let's see. That surgery of the umbilical hernia did not note any use of mesh either. I was able to run 8 miles a day or less, or more. Hold on. I was able to run 8 miles a day or more less than a year ago, and bicycle ride 10 miles several months ago with no issue. My abs have been very strong due to the amount of activity I do. I saw 2 acupuncturists for a tight jaw muscle, and they both targeted my abdominals, which seemed to change my abdominal form. Now I can hardly bend over or walk. My abdominal muscles feel like concrete, and I'm having trouble relaxing and even breathing. I'm worried that mesh was put in without my knowledge. Ventrolite mesh was listed on the surgical report, but not listed as used. Is it possible to see this kind of mesh on a scan? I had a CT scan, but they didn't see anything notable. Okay, great question. First of all, the opera report, there are 2 things to look for if you think, 3 things. If you think you had mesh in you and you're not sure. Number 1, read your surgical opera report dictated by your surgeon. That should say, I put mesh in or I didn't put mesh in, number 1. Number 2, there's implant logs that are mandatory. So whenever any implant is placed in a patient, that needs to be logged in with a lot number. That is usually not in your surgical op report. You have to specifically ask for that report from the hospital or surgery center where you had the operation. It's oftentimes in the nursing notes, or there's a separate implant log form where they log in the implant. If that implant was logged in, then most likely you had that implant in you. Okay. And it's uncommon, but it's possible from human error that your opera report did not include the mention of the mesh because of like some force, like they missed it or something for some reason. But that would be uncommon. If you can also see what you were billed for. Look at your billing invoice. Were you billed for mesh or were you not billed for mesh? So those are 3 ways to figure it out. The opera report by the surgeon, the nursing or hospital or surgery center implant log, and your bill to see if you were billed separately for the mesh. Now, CT scan will often not show the mesh very clearly because it's gray looking usually, and your muscles also gray. So gray on gray looks exactly the same, so it's hard to tell. What you can do is get an MRI. An MRI will show if there's any permanent suture or permanent mesh in that area pretty reliably. You would need a non-contrast MRI ordered of that area of your body just to identify whether you have mesh in you or not definitively. I've had people coming to me saying they've been sick ever since they've had mesh in them. And I'm like, you don't have mesh in you. Yes, I do. I know I had mesh in me. My surgeon told me I had mesh in me. I'm like, but your opera report doesn't say it. And the implant log doesn't say it. And sometimes these were like 25 years ago, 35 years ago, where they claimed they had the surgery. And so I would get an MRI and of course also no mesh. And in one case, I even called the surgeon who was retired and he said, this was a tummy tuck. He's like, oh, I've used maybe 2 or 3 patients where I've had mesh in them for a tummy tuck. She was definitely not one of them. So no, I can guarantee I did not put mesh. So implant log, opera report, nursing notes, billing, and then MRI. Thank you. That was a terrific response to explain Dr. Zolan's observation. Oh, you're welcome. All right. We're caught up with some of your questions. So the next is, when do hernias cause abdominal pain? And everyone's variable. So you can't say, like the last patient who had the question, oh, you have belly button hernia, that can't cause your pain. That's not correct. In some people it may, in others it may not. You can have small hernias with an itsy bitsy piece of fat in there, horrible pain, like especially in athletes because they really know their body very well. Or you can have a huge hernia with tons of bowel in it and no pain, and some combination thereof. So it's unclear which hernias and which types of hernias, which size hernias cause pain, but they do cause pain, not all the time. That's kind of the area where there's kind of shadiness in there. So when do hernias cause abdominal pain? Usually it's if something is trapped in it. It's like bowel or even fat. And that's often when the neck of the hernia, the hole, is smaller than the content that's trapped in it. So if I give you a ring that's smaller than your finger, that's going to trap the blood flow there and cause you pain. You can never wear a ring that's smaller than your finger side. It's just uncomfortable, or you'll lose your finger. So the same thing is true for a hernia. The amount of content that goes into the hernia defect, if it's tighter and more than the actual width of the neck of it, then that is a problem and can cause pain. The other reason why hernias can cause pain is if they're actively trying to tear. So if you've had surgery and you have pain, often it's because the muscles are trying to pull away where the surgery was. That's why we moved away from tissue repairs, both for ventral hernias and for inguinal hernias, and more towards mesh-based hernias, because oftentimes what's happening is you get chronic pain because you're constantly trying to tear at the tissue levels. And once you do tear and you get another hernia, then that hernia will be even more difficult to repair because now the hole is bigger and you have less tissue that's healthy to close it. So hernias cause pain if something's being pinched or if it's trying to tear away from the suture line. Let's see, we got another question. I've had several abdominal laparoscopies for endometriosis and uterine suspension, perforated diverticulitis with abdominal abscess, ileostomy, resection, 4 ventral hernias, 3 with bowel, and now 2 more ventral hernias. I have been turned down by 2 surgeons already just to be seen. My colon surgeon wants me to consider an abdominal reconstruction and see a hernia specialist. Can you discuss abdominal wall reconstruction? Oh, absolutely. I would love to. That's why I'm here. So abdominal wall reconstruction typically refers to a hernia repair that requires more than just closing the hole or patching the hole. You need to reconstruct it because it's a complicated situation. Either the holes are too big, too wide, multiple, or in weird areas like the side or the flank and so on. And so your surgeon is correct. It should not be addressed by your average general surgeon. Most of them are not skilled and don't understand the intricacies. Almost tried to sneeze there. Most of them don't understand the intricacies of how to perform these and therefore to perform it well so you don't have a problem or complication from the operation. So there are multiple surgeons. I have personally interviewed many of them because they're the ones who I feel are very skilled on HerniaTalk live. And so you can kind of seek their consultations for abdominal wall reconstruction. Of course, I also do abdominal wall reconstruction. So what it involves is really reconstructing and rearranging your anatomy a little bit. So the typical anatomy is the rectus muscles in the middle and then the 3 sets of obliques on the side. If you have a lot of holes, and sounds like you do with bowel in them, etc., some of those holes can be closed, but some of them may not be just able to be closed because it's too wide. So you have to shift the tissues and the muscles against each other to be able to overcome the tension of just closing a very wide hole. And that's part of the reconstruction. Terms that people may use is a TAR, which stands for TAR, transversus abdominis release, ETAP, which we discussed 2 weeks ago, TAP, RTAP. These are all different terms they use. Reeve, STOPA. These are posterior component separation, anterior component separation. These are all various techniques that are used. Now, before you go into any type of surgery, you must make sure you are not overweight and definitely not morbidly obese, because that is a disaster scenario where you're needing surgery, but your weight is to the point where it's adding a lot of tension to the repair, and they either can't do a good repair, or if they do a good repair, it's under tension because there's all this other abdominal fat that's pulling on it, and then it will recur, and now you have a failed abdominal wall reconstruction, which you definitely don't want to have, and you'll need another operation, which is an even smaller range of surgeons that are able to do that. So my suggestion is do your best to reduce your risk factors for surgery. So no nicotine, make sure your diabetes is well controlled if you have it, no cough, no constipation or straining, you're female, so you can't have prostate issues, and then not morbidly obese, and then definitely go seek an abdominal wall reconstruction surgeon. The recovery is often long, unless it can be done robotically, in which the recovery tends to be short. So those are actually kind of fun to do. And recreating the abdomen is really fun because you end up really reconstructing to a flatter look, less pain, and so on. I love it. Next question. I'm dying to hear about the boy whose pain was relieved by the hot bath patient. Yes, thanks for reminding me. Okay, you know what causes abdominal pain that's relieved by sitting in a hot tub or a hot bath? Marijuana. Use of marijuana. This kid was using marijuana. I think his friends were slipping it to him. Of course, we're in California. This was a while ago. So marijuana, some people get a bad reaction to marijuana. That reaction is abdominal pain. And classically, that abdominal pain gets better if you sit in a hot bath. We think it has to do with the blood flow to the intestines, and somehow the marijuana either reduces the blood flow or causes spasm of the arteries and so on. Because he wasn't losing weight, actually. He was a chubby kid. So it's not like he was in so much pain that he wasn't able to eat. He had a full workup, endoscopy, colonoscopy, tons of CAT scans, angiograms to look specifically at the blood vessels to see if they had any disease. Totally normal. I don't believe he had surgery, so that's a good thing because he didn't need it. But unfortunately, he's one of those people that has an allergy or a reaction to the use of marijuana. And so that was a medical cause for what was considered to be a surgical problem, which is just abdominal pain with meals. So I love it. Thanks. It would be horrible if I went through this whole Hernia Talk Live scenario and forgot to give you the answer. Kept you hanging. Okay. Why don't doctors diagnose hernia as the cause of my abdominal pain or my pelvic pain? That's a great answer. I think similar to the question that was asked a while ago, doctors discount how many symptoms you can get from a hernia. You can get bloating, back pain, nausea, pain with bending and sitting, a lot of symptoms that you can get from a hernia that people don't usually associate with. They think you have to have pain exactly at the hernia. So women can have pain with intercourse, pain in the groin, in their pelvis with their periods. And of course, they'll be sent to a gynecologist for that, not to a hernia surgeon. But the hernia is the cause of their pain. Men can have testicular pain. I see a lot of men with testicular pain. Now, often that's not caused by a hernia, but it can be. And so if you can't figure out why you have testicular pain, let's look at a hernia as a possibility of your pain. So the problem is that hernias are not well taught. It's very common. It's kind of like considered, it's just a hernia. So the medical school curriculum glances over it, even though it's one of the most common diagnoses. Medical doctors, family medicine, gynecology, gastroenterology, even general surgery, urology, they discuss it, but they don't, if anything, they discuss how to fix it. But how to really diagnose it and feel for it, they're not very good at that. So surgeons and doctors are very surprised. Oh, you can get bloating from a hernia? Oh, I didn't know you can get nausea from a hernia. Oh, it can cause back pain? I didn't know that. So it's one of those things where it's just not appreciated, and not every patient is textbook. And so it's very important that doctors are open-minded, because not every patient's the same. Next question. Have you heard of placental cell allograft, stem cells, or other biologic used to promote healing after abdominal wall reconstructions, or even after regular hernia surgeries to promote healing and prevent adhesions? Great question. Yes and no. So we don't actively use stem cells for anything related to the hernias, although I'm sure there's research ongoing where we're hoping that an injection into an area will either prevent a hernia or help heal a hernia, so that the areas where the collagen, let's say it's mismatched, maybe it'll increase the level of mature collagen in the area, or MMPs and other proteases in the area can be altered with injection of these stem cells. So there is very little, but there is research in looking at that. In terms of injecting things to promote healing and prevent adhesions, there are synthetic cells. I don't want to call them stem cells. They're like amniotic cell sheets, very expensive, that you can place in certain areas to promote healing. Very expensive. It's questionable whether they really work, but they're amniotic sheets, cell sheets, that are commercially available that you can use to help reduce scarring and scar formation and promote healing in the area. So yes, there is that. Look at all your questions. Let's see. I do not use marijuana, but I have chronic inguinal pain without hernias, but maybe sports hernia that is relieved temporarily by the use of a hot heating pad for several hours. What are your thoughts on this? So just to understand heating pad versus cold packs. If you have inflammation in the area, that inflammation is from a hernia, from a muscle tear, then cold packs, ice packs work the best. And the reason for that is it really kind of reduces the inflammation in the area, reduces blood flow to the area, less pain, and lasts a very long time. If you have a muscle spasm in the area, not a muscle strain or sports hernia, but a muscle spasm, then heat packs can increase blood flow to reduce the spasm, kind of like, what's the right term? Like kind of soften up the muscle a little bit and reduce the spasm. So heat packs work for muscle spasm and cold packs work for inflammation. So I would try cold packs or ice packs for your chronic groin pain, maybe due to sports hernias or muscle strain, and see if that actually gives you more relief. Because if you're also taking, let's say, Aleve, or which is naproxen, or ibuprofen, which is Advil, which are both anti-inflammatories, then ice pack will be a nice adjunct, because that's also a very strong anti-inflammatory. Next question, can you mention what type of CT scan is best to diagnose a hernia, as just laying down may not show it? Excellent question. I had a whole section, I think, on radiology. Yeah, I had a whole HerniaTalk live on radiology alone, and what to order and how to order it. So I highly suggest you go to that episode, which was, I think, within the past 6 months. CT scan is best for ventral hernias, so abdominal wall, umbilical, all those. And it can be ordered with oral contrast, which means you drink the contrast because at least that'll differentiate intestine from everything else. And on the report, it's a request, it should say with Valsalva, which is a bear down view. So you add the Valsalva. It's often not a good test, so I prefer ultrasound or MRI for those. And both of those are dynamic or test with Valsalva. So hernias, if you really want to do a really good job to look at hernias, especially occult hernias, you want to use things with Valsalva or bear down views. But if it's a big hernia and you just want the imaging to demonstrate, what's going on there and not necessarily actually diagnose the hernia, then a CT scan just flat is perfectly fine. Next question. A muscle spasm in the abdomen comes and goes and inflammation is all the time usually? No, not necessarily. So inflammation can occur because things are trying to struggle to go into the hole, for example, or trying to pull things apart. Whereas at rest, you may not have inflammation. So inflammation can come and go as well as muscle spasm. Next question, is pain surrounding an area of nerve damage a common thing? What specifically may cause this? So if there's an area of nerve that's damaged, whether it's by surgery or trauma, there's really no other reason for it to be damaged, then the pain would be along the length of the nerve. So the nerve starts the spine, actually starts the brain, goes down the spine, comes out of the spine towards whatever area. So the groin, for example, wraps around the back and then towards the groin and then maybe the inner thigh. So you would get pain along the length of the nerve, but you should not have pain surrounding the area unless there's another cause for pain in the area. So let's say, for example, you have nerve damage from a hernia repair because the nerve is entrapped or was accidentally cut or injured as part of your hernia repair. That's fine. You can also have pain from the actual hernia repair and the mesh, let's say in that area, which is separate and maybe contributing to why the nerve was damaged. However, if you just have isolated nerve damage and nothing else, then the only pain you should have would be along the nerve itself. You guys are asking great questions. Got a couple more minutes, so let's go through. Let's see, one more question. Can I have hernia pain? Can I have hernia pain and some other ailment causing my abdominal pain? Yes, I kind of alluded to that earlier. So a good clinician should be able to identify the hernia and figure out what percentage or component of your pain is due to the hernia, and then what component or percentage of the pain is due to something else. For example, I had a patient, I think this was yesterday, it was a telehealth, and I was trying to kind of really figure out for him what part of his pain is hernia pain and what part of his pain is pudendal pain. So because his pudendal pain, thank God, is much better with injections. The pudendal neuralgia, he had perineal pain and kind of anal pain. But the bloating that he had, the nausea, the groin pain, the testicular pain, the pain wrapping around the back, that was all inguinal hernia related pain. So you can have multiple problems at one time, especially with hernias, because hernias are so common and many of them are so asymptomatic or minimally symptomatic that it's really important to understand that you can have many, many other types of pain and also have a hernia, but it's unrelated to the fact that you have a hernia. It's one of those things where you really need to just have a great surgeon help figure it out, because that's where the whole that's where the fun of it is, like how much of this is what, and then you can do like a nerve block or certain type of medication or change certain activities and then be able to figure out what causes which pain. All right. The time has come, everyone. Thanks for joining me. That was a fun one. It was like rapid fire. I like that. Rapid Fire Hernia Talk. I should change the name to it. So that was fun. We should do it again. We will do it again next week. Thanks for joining me, everyone. Follow me on Twitter and Instagram at HerniaDoc, on Facebook at Dr. Towfigh. I will promise I will post last week and this week's episodes on YouTube. So follow me on that channel and just watch it.